Hello everyone, this is Dr. Tushar Mehta. I'm an orthopedic surgeon here, faculty of orthopedics. Well, this question has been popping up on my social media time and again, and students are messaging that what should be the correct answer. Well, let's read the question. A 2-year-old child has rickets and he's on some calcium supplement and he has CTV. Well, uh, CTV is not a very specific term. He can have any deformity. Now, question is he should be referred to the surgeon for correction of the deformity when? Four options. Vitamin D is normal, growth plate is healed, ALP is normal, calcium is normal. I'll tell you and we'll find out the reason behind it. Well, before I tell you the correct answer, let me tell you that this kind of a scenario we are almost in this scenario in our OPD almost on a weekly basis. Like every week, 1 to 2 patients come to me like this. So I'll tell you what we do. So OPD, next patient, please. Yes, sir. Tell me, doctor. Basically, I'm the father and he is my 2-year-old son. Okay. Doctor, actually, for last couple of weeks, I've been noticing that when he's walking, he's not walking properly. Oh, show me. Oh my God, sir, he has rickets. He has bow legs. Yes, doctor. Sir, actually, there's an MCQ that most common cause of rickets in children is basically most common cause of bow legs is basically genovirus is basically rickets. Yes, doctor. Sir, so what I feel is that your son has most likely rickets, but sir, you know what? We need to prove it. So, doctor, that's why we are here. Sir, actually, let us do some blood test. Let us do this. Let us do this. Let us do this. And let us do vitamin D3 also. So, let's do the calcium profile and see you tomorrow. Next day, father comes back. Calcium is low, phosphate is low, ALP is high, vitamin D is low. I'll tell you why. Everybody knows that rickets is due to vitamin D deficiency, yes or no? Yes, so vitamin D has to be low. Now, if you remember, then vitamin D helps in absorption of calcium from the gut. So, if you have less vitamin D, then calcium will not be absorbed from the gut into the blood, so calcium will be low. Calcium and phosphate are brothers, both go together. ALP is a reflector of osteoblastic activity in children. In rickets, osteoblastic activity as a compensation is always higher, so ALP is high. Let's say it is 150. Let us say it is 150. The normal value is 40 to 140. Patient has, okay, let's say it is 450. Patient's value is 450. Normal value should be 50 to 150. Now patient says, doctor, so you got the blood test, so now are you sure that my son has rickets? I said, no, I need x-ray of both the wrist, because in radiology I'm sure you must have been taught that there are certain metaphysical signs of rickets. They can be cupping, they can be splaying, they can be fraying, they can be anything. Next day when they come back with the x-ray of both the wrist and I see metaphysical signs, and then I tell them that now I am absolutely convinced that your son has rickets and we need to start treatment. Doctor, what should we do? Sir, initially we should give him a loading dose. In the loading dose, we will give him injection of vitamin D3, which is available in the market in the form of 6 lakh international unit. Sir, we will give this injection deep intramuscular and of course after sensitivity test dose. Then we will put him on oral vitamin D3 supplements, let us say for 6 to 10 weeks. And sir, I insist that we see you again after 6 to 10 weeks. 6 to 10 weeks later, follow up is necessary. They come back after 6 to 10 weeks, 6 weeks, 8 weeks, 10 weeks, whatever. Three possibilities. First possibility, tuck. The father says, doctor, I was just passing by. I thought I'll just say thanks to you and I've got some sweets for you. Why? Doctor, actually, the problem is sorted. What? Yes, doctor. The genovirus, the bow leg, which my son had, that is absolutely correct. Now everything is fine. Since, doctor, I think you treated the root cause rickets by giving bolus of vitamin D, I think the problem got corrected. So, thanks to you. Guys, honestly, this is hardly in 5 to 10% of the cases. What happens in majority of the cases, when they come for follow-up after 6 to 10 weeks, they come to us and they say, doctor, you had called us today. Yes. For what? Doctor, because we have called us because of follow-up. Yes, yes, I called you. So doctor, the problem is still persisting. What? Yes, doctor. It is still persisting. Okay, nice. Problem is still persisting. Nice, nice. Sir, I have treated your son. Today, I want to see whether the treatment is on the right track or not. If you have a disease and the test tells you have a disease, the test is diagnostic. If you have a disease, I treat you and I want to do a test to tell whether treatment is on the right track or not, test is prognostic. Sir, I need to see that whatever treatment we have done till now is on a right track or not. So we need to do a prognostic marker. For that, what we need to do is a serum alkaline phosphatase. What we need to do is a serum alkaline phosphatase. Come on, let's do a serum ALP. Next day, father comes back with his son. Guys, believe me that alkaline phosphatase has shot up to 950. Father is very angry. He said, Doctor, last time when we came to you, his ALP was 450. You gave enough of vitamin D. Despite that, ALP has gone up from 450 to 950. Doctor, do you even know what you are doing? I said, of course I know. I said, sir, this is a concept. Your son has rickets. Yes. We gave him vitamin D. Yes. Did he respond? No. So that obviously means that your son is a case, not a case of VDDR. He's a case of VDRR. He is not a case of vitamin D dependent rickets. He is a case of vitamin D resistant rickets. Sir, let me tell you very honestly, sir. There is some problem in his kidney, sir. It is a case of renal rickets. Sir, there must be some glomerular tubulointerstitial disorder. That is the reason behind it, sir. I'm telling you, sir. Sir, there must be some vitamin D losing nephropathy or some vitamin D receptor insensitivity because of which it is happening. He said, Doctor, I don't care. Just treat the problem. I said, I can't. It is a problem of a kidney. I'm a guy who deals with bones. I can see only bones. I have a tubular vision. Kidney has no bones. So you should go to a pediatric nephrologist, because unless and until those problems are not sorted, I'm not the correct guy for you. This happens only in 5%. So what happens in most of the cases, like 90% of the cases, when they come back to us for follow-up after 6 to 8 weeks, we do their prognostic marker ALP and they come back next day with a smile on their face, because ALP, which was 450 6 weeks ago, has now come down to 75, which is between the normal value. They come to us with a smiling face. They say, Doctor, you know what? Deformity is still there. We're happy with one thing, that ALP has come out to be normal. I said, even I'm more happy than you, because we have treated the root cause of the problem called rickets, which is totally under the control. That is why ALP has come down to normal. But what about the deformity that has already happened? We can correct it only with the help of surgery. See, a bone was supposed to grow like this. ALP was high, so it was growing very fast, very fast, very fast. I'll repeat again. A bone is supposed to grow like this, okay? But the deformity happened, so bone had started growing like this, and ALP was very high. So that means it was growing very fast, very fast. The deformity was growing very fast, very fast. Now ALP is normal, so that means that speed is gone. No speed now. But whatever deformity has happened, we have to correct it. Yes or no? Yes. How do we do that? Surgical correction. You have tackled the underlying cause, but whatever deformity has developed, you have to perform a surgery, a corrective osteotomy to correct the deformity. So technically, the decision of doing the surgery was taken only when what comes out to be normal, alkaline phosphatase. So a simple question with a very simple answer, alkaline phosphatase, when it comes out to be normal, then only the decision for surgery is taken. But it had to be explained on a clinical basis, and that is the only thing that I've been doing for last 15 years. And that is the only thing which honestly I know. I don't know any other way to teach. So if you try to develop a clinical anecdotal way of learning and understanding, believe me, you will be able to solve any question related to this topic, whether they ask you in any form. I wish you all the best. Please like, share and subscribe to the channel, and stay tuned for more updates like this. Thank you.